Greetings from Kodwani Hospital. Fissure in ano, just touch and go, the basics. What is fissure? Fissure is a tear or split in the anoderm, just distal to the dentate line. This is the representative photo of fissure in ano. That's a classical triad of sentinel pile, heaped up fissure with the scarred edges, and there is a hypertrophied anal papilla proximally. So this is the photograph of a fissure in ano. Again, this one more photograph is there. Now, depending on the chronicity, depending on the time duration, this is just a touch and go. That's why I'm in speed. There are two types of fissure. One is chronic, one is acute. The acute anal fissure, that's having duration of less than 6 weeks. And the acute fissures are caused by mechanical force generated by the passage of large bowel or maybe friction of the hard stool through the anal canal. And the posterior midline fissure is 90% in females and 99% in those that is in males. Now the theory, the etiopathogenesis of the fissure is the decreased blood flow or increased mechanical stress that may count for the propensity of these fissures to occur at that location. And there's a theory of ischemia. It says that there is a comparatively less vascular supply to the posterior midline, and also the repeated injury, maybe hard stool or maybe the increased bowel movements that may result into the development of the chronic fissure. So this is again one type of fissure, and this is a small child. This happened because of wet nappies and fungal infection over there. And clinical evaluation, as you all know, its symptoms everybody knows. I will skip this slide. And physical examination, again I will skip this slide. The diagnosis best made by the careful history and the gentle examination. Mere splitting of the buttocks will show you the fissure over there, and the bleeding sometime occurs, sometime may not occur, and the pain, it persists after the motion, maybe for 10 minutes, maybe 30 minutes, or maybe in chronic fissure it persists for the whole day, and the patient feels difficulty in sitting upright into the chair. So pathogenesis of the fissure, the exact etiology again remain uncertain. Typically it occurs because of passage of a large hard stool or frictional trauma, that's what I said. And fissures can occur in absence of any trauma or constipation also. The theories are, as I told you earlier, the mechanical theory, the anorectal angle that creates the greatest stress posteriorly, and the pathogenesis continued. Sphincter hypertonicity, in most of the cases, it is the internal sphincter which maintains the anal tone. It is the hypertonicity of the internal sphincter that is responsible for causing the fissure. And ischemia, that's what I have told earlier. Now coming to the management of the fissure, the key concepts in the management of any fissure should be in acute anal fissure, where the symptoms are less than 6 weeks, it is likely to heal with dietary modifications, lifestyle change. And in chronic anal fissure, where the symptoms are extending more than 6 weeks of duration, the topical nitroglycerin or calcium channel blockers yields better results than the placebo. And those patients who are not willing for the surgery, their Botox treatment can be considered. And where those all remedies fails, then you need to go for surgical intervention, where lateral internal sphincterotomy remains the gold standard for the treatment of fissure with its inbuilt pros and cons. Now coming to the medical management of the fissure, the acute anal fissure, where the history extends from less than 4 to 6 weeks. And here we can offer the non-operative treatment to the patient, where fiber supplement and plenty of fiber. As Dr. Jiten, my friend, told already, the Indian food diet is already rich in fibers, where the Western people, they go for pizza and there's a lot of many Chinese foods which are less in the fiber food. So we don't need additional fiber food by yellow, volo, nothing. Just routine Indian diet is sufficient, rich in fiber. And stool softeners, yes, as we emphasized earlier in my earlier talk. And generous water intake should be there. This should be in a part. Seeds bath, I'll be covering this in detail in my next slides. The local anesthetic ointment, maybe diltiazem with the lidocaine should be, or with steroid should be applied. and rapidly alleviates the symptoms and brings about the complete healing. Now coming in detail to the seeds bath, friends, what is the routine seeds bath what we are offering to the patient? We ask the patient to take a bowl and just dip the anal area, just dip the buds into that. Do you feel this is a bath? No, this is immersion. But what is bath? Bath is a cleaning. आप जब bath लेते हो, when you take bath with the bucket and the jar, you move the water with the jar. The person is static. When you are standing under the shower, the water droplets are moving, the person is static. On the contrary, when a person goes for swimming pool, the water is static, the person is moving. So either the agent or the object has to move in the bath. This is not the bath. This is seeds immersion. We are carrying this misnomer since 2.25 centuries, because seeds bath was introduced in 1800. Since then we are taking this seeds bath. This is not bath. This is seeds immersion. This is the bath. Actually, this one is the seeds bath. Now, these are the complications of the traditional seeds bath. This is a skin burn. This is a case from one of the renowned hospital in the Mumbai, and anyhow with the very great difficulty they averted the criminal and consumer litigations. These are the other complications of the traditional seeds bath you can have, and these are the kits which are available for the seeds bath, and this produces a mild jet effect. Again, this produces a spurt with the mild jet effect, hardly displacing 5 to 7 mm of water depending on your fist power. Jai, 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 ek baar jo jawan terna. So that was the seeds bath innovated by Salu Hai. But this is the best way in my opinion.
सीड्स बाथ फाउंटेन को कमोड पे रखें, वाटर लेवल तक गर्म पानी डालें, उस पर बैठे और बटन दबाएं, बटन ऑन, दर्द गॉन.
Now continue with the medical management of the fissure. Second talk भी मेरा ही है. The chemical sphincterotomy, the calcium channel blockers like diltiazem or nifedipine, the success rate is 65 to 85%. Glycerin trinitrates, these are the topical application. These works by the vasodilatation and relaxing the internal anal sphincter. Botox, botulinum toxide, if the patient is not willing for the surgery, where the success rate depends on the repetitive doses, it increases from 60 to 85-90%. And of course, high fiber diet, plenty of oral fluids, and stool softeners should be in your prescription pad with maintaining the local hygiene, and anyhow to avoid the prevention of the hard stool and avoidance of constipation. Like he has to change his habit, he should not take his laptop, newspaper or mobile phone or WhatsApp or Instagram to the toilets. He should go barehanded, should come early. Now continue to the medical management. The chemical sphincterotomy, calcium channel blockers like diltiazem and nifedipine. It relaxes the internal anal sphincter, and internal anal sphincter cell contraction, it depends mainly on the intracellular calcium ions. And the CCB, it causes the smooth muscle relaxation and vasodilation. It increases the blood supply to that area and adds nutrient, adds oxygen, and takes away the P substance with the increased blood flow. And this is how it decreases the resting anal tone of the anal sphincter and causes healing of the fissure. Continuing with the clinical sphincterotomy, glycerin trinitrate topical application, the healing rate is 40 to 68%, but because of incidence of severe headache, nowadays nobody is using this. Now coming to the Botox, Botox is a minimally invasive treatment for chronic anal fissure in the adults. This causes relaxation, rather paralysis of the internal anal sphincter, and the internal anal sphincter relaxation, it decreases the anal pressure that leads to the increased blood flow as it occurs with the diltiazem and glycerin trinate also. Now Botox is available as a 50 and 100 ml unit vials. The indication for the surgery, as I told, the persistent sphincter spasm secondary to anal fissure after failure of conservative and medical management, which may be after more than 3 weeks. If it has failed, there is an indication for the Botox, and where the patient is having good amount of money in the pocket and if he is not willing to go for the surgery. Now contraindications for the Botox therapies is skin inflammation around the fissure with the abscess you should avoid, and the history of reaction to the toxins or albumin, egg albumin, if it is there, you should avoid the Botox. Pregnancy and lactating mother is a contraindication, and the pre-existing motor neuron disease and myasthenia gravis again carries a contraindication for Botox. How to prepare? Just in short, a 50 ml vial is taken, reconstituted with 2.5 ml of distilled water, and tuberculin syringe with 26 gauge needle is taken, and it is injected into the internal anal sphincter on 2 sides of the fissure, and the injection should be normal muscle away from the base, away from the fibrosed area of the internal sphincter, and if it requires, it can be repeated in 4 to 6 weeks of time. The success rate after first dose is 60 to 88%, and success rate after the second dose is 99%. Management of chronic anal fissure, as I told, it's more than duration of 6 weeks, which responds to non-operative treatment. The surgical procedure is to be adopted. Another talk, some few videos are there. Can I have the second one? Surgical management of fissure. The indications I have already enumerated. The primary goal of the surgical treatment in chronic non-healing of the fissure is to decrease the resting anal tone of the internal sphincter, because it is involuntary, that is causing increasing in the tone. Normal tone is 40 to 50 millimeters of mercury, and with a squeeze pressure it goes up to 90. Any resting anal tone more than 100 is an indication for surgical intervention. The first one is anal dilatation, but now nobody is doing this. Lateral internal sphincterotomy is a gold standard, and fissurectomy, flap advancement, I will cover short by short. The anal dilatation, the various methods like 4-finger method or dilators are there. Normally 40 mm diameter is sufficient for females, and 45 mm diameter dilatation is sufficient for the males. And without damaging the internal sphincter fibers haphazardly, we can go up to 60 mm of dilatation. And because there is no standardization of the anal dilatation, that's why this anal dilatation has come under cloudings. Lateral internal sphincterotomy is a gold standard, and initially it was done at 6 o'clock position, but because of keyhole deformity, as Dr. Ganga Shankar has already enumerated, it should be done at 3 or 9 o'clock position. This is the open internal sphincterotomy. This is a pictorial, and this is the very small video of, we are going into the intersphincteric groove. Medially is the internal sphincter, laterally is the external sphincter. This is the groove I am showing. With the 11 number bayonet knife, I have given a horizontal small nick, 4 to 5 mm nick. I will hook it up with the small curved mosquito artery. Take out the white, glistening, hypertrophic internal anal sphincter fibers. You can see those white fibers coming out by hooking up with the artery forceps. This has been hooked up. With the cautery or scissor or blade, whatever you prefer, or laser, you can do the sphincterotomy. That's how the surgery is over. The complications of open sphincterotomy, although it's a gold standard treatment, but persistent incontinence for the gas or the stool has emerged as a major concern, and inadvertent division of the internal sphincter affects the overall healing. Now this is a closed sphincterotomy. This is done with the cataract knife. This is a cataract knife, you can see. Again, there is a small video.
I have taken Lignox jelly in my left index finger. I will insert this and lubricate the anal area. I can feel the internal sphincter over here, and between this groove, you can appreciate this groove. This is internal sphincter, this is external sphincter. Between this groove, I will enter with this is a cataract knife. You can see this cataract knife. This is having sharp edge at one place, another space is another edge is the not sharp. So keeping my index finger, left index finger into the anal canal, making the internal sphincter prominent, and I will insert this cataract knife between the groove of external sphincter and internal sphincter, keeping this sharp cutting edge medially towards the anal canal. Let us see. I have inserted this, and over my finger I am cutting this internal sphincter. I can feel the movement of blade. This index finger I have put inside to prevent any mucosal tear. Yes, I am cutting this internal sphincter fibers.
Very slowly you have to cut, very gradually you
I
have
have
to
cut the
cut.
internal sphincter fibers. Let us see. Smoke करो. Press करके रखो. Yes. What earlier I was feeling as a tight internal sphincter, now the sphincter has been relaxed and there is no tightness. The tone has been reduced. Although the patient is in saddle block.
If there is a bleeding, you can have this pinch cock effect with the thumb and the index finger.
I have taken Lignox jelly.
Sorry. One point of notion I would like to make over here, doing with the cataract knife, one can have a tumescence effect over there. One can instill normal saline or distilled water with adrenaline, so that it creates a space between the mucosa and the internal sphincter, so the mucosal tear can be avoided. Otherwise also your index finger is guiding, but better will be to put distilled water and adrenaline to prevent it, to have a tumescence effect. So it will make away the mucosa from the internal sphincter. Now this is a bladeless lateral internal sphincterotomy. This is done with non-scalpel vasectomy set. So these are the, this is a Fissure case. Yeah, this is for last video.
I have put my left index finger after Lignox jelly inside the anal canal. Now I am feeling the internal sphincter.
This is the last video.
Now here at 3 o'clock position, these are the instruments. These are the non-scalpel NSV set, non-scalpel vasectomy set. So with this fine artery, I will go into the intersphincteric groove here, over here. I have gone inside.
This recording is done by a non-professional person, so maybe some movement is there.
I have stretched a little vertically. I will put this instrument from this hole inside, go medially and get hold of the internal sphincter. You can see these fibers of internal sphincter I have got hold of. One more forceps I will use to hold the lower part of the internal sphincter. You can see this white glistening very fine internal sphincter, and I will go with this for the cauterization. Left to नीचे नीचे left. इसको पकड़ो. I will cauterize this. Yes.
Once these fibers are cut, you have to check again.
Released one forceps and we'll see if there are internal fibers again. If there are internal fibers, we'll cut those also, and we'll assess the tone, how much is released.
You have to see whether
Now
some fibers
the
are
complete tone
remaining.
has been released, the complete fibers have gone, and our surgery is over. I have put my left.
So pros and cons of bladeless LIS. They're easy to learn and perform. The less instruments are required. No costly gadgets are required. It is done under vision and no hematoma occurs. It's smooth and faster healing occurs. And pros and again cons, the sometimes mucosa may get catch hold in the forceps, you have to be very careful. The iatrogenic mucosal tear, but that is a repairable one. The fissures with hypotonic anal sphincter. Hypotonic internal sphincter, mostly in obstetrical injury this happens where there is a tone of the internal sphincter is less. So there is internal sphincterotomy is contraindicated where you have to go for advancement of the flap surgery, mucocutaneous flap. Laser internal sphincterotomy, I'll skip. I'll request Dr. Kalyankar sir to cover this laser topic. And this is the flow chart algorithm for the treatment of the anal fissure where hypotonic internal sphincter there. You can have the photograph of this flow chart. Take home message. The treatment of fissure is a rewarding work for the patients. Sometimes the patients keep on suffering for a couple of years, and when surgery is done, they put their hand on the forehead. अरे यार पहले क्यों नहीं करवा लिया, क्यों इतने दिन भुगता मैंने, कहाँ था यार तू पहले डॉक्टर. So this thing happens. This is the most rewarding surgery. One should master the technique of their own choice. Maybe a laser, maybe open, maybe closed, maybe with the NSV set. You can master it. These are very simple surgeries, and at the same time keeping all the techniques available to offer the patient at their choice. Now LIS is done up to the fissure level. It's most rewarding, and up to the hypertrophic internal sphincter only, it yields best results where no fecal incontinence occurs. But if division of internal sphincter done to the dentate line, it may cause anal incontinence, so that's not advisable. Thank you so much, and if you have any question, thank you. I'll be happy to answer. Please have a mic over there.
It's a wonderful presentation, sir. My name is Dr. Manmohan.
Thank you, Manmohan.
Sir,
Thank you, Manu.
Thank you, sir. So I have 2 or 3 questions. Wherein,
Please.
like for a closed LIS,
Huh.
like what are the chances for fistula formation?
See, it's a iatrogenic mucosal tear which happens, and if you come to know on the table, you suture it with a 3O vicryl, there won't occur any fistula.
So regarding closed LIS with fistula and fissure and fistula in
Yeah.
like whether you are going to go for a closed LIS?
It should be open. You are already operating for the fistula, it should be open one under vision.
Yes, sir. For the Botox, whether you are giving any test dose before, because for the allergic reactions, we are like,
It's advisable. It's advisable, and already you have to take the history of any anaphylaxis or any reaction, any allergy, even the yolk of the egg, one should ask the history.
Thank you, sir.
4 to 6 weeks, because in 6 weeks time that goes into the chronicity, and that's very difficult to heal.
Okay. That application regarding the ointment.
4 to 6 weeks that I have
Is it
told.
intraanal or perianal or both, or how to apply ointment?
It's intraanal. It should be applied with the finger gloves. Or applicator is there. Some people are scared because of pain. They are not able to inject. They are not able to insert the applicator. So ideally, it should be to the fissure bed. It should be applied, not the externally.
Okay.
That has to be. That has to come in your counseling to the patient. Please. Sir, if you do the sphincterotomy up to dentate line, the chances of incontinence will be there. It's only up to the fissure bed you should do the sphincterotomy.
Mentioned we can able to do sphincterotomy up to the dentate line.
No, maybe by mistake, but no, it's not advisable. Fissurectomy, internal anal sphincter has to be cut up to the fissure level only, fissure apex, up to the fissure apex.
Okay, sir. Thank you.
If you point it out, I will see the slides, I'll make it correction.
Sure. Thank you.
Thank you so much.
The classical teaching is convention sphincterotomy up to dentate line you can do. Later what sir said incontinence observed.
That was old school of thought.
We
up
have
to
modified
dentate line.
it. Something called as tailored sphincterotomy up to
Yes.
the apex of the fissure bed.
Apex of the fissure.
Something called safe sphincterotomy in females, only 1 centimeter of your sphincter. So these are the three types of sphincterotomy. One more is calibrated sphincterotomy, where you will put the dilators and see how much of the anal canal dilated. 3 centimeters, 3.5, 4 centimeters. In females beyond 4 centimeters, we don't dilate. Okay,
Yes.
thank you very much.
Thank you, sir, for sharing your experience with
Thank you
us.
so much. Thank you very much.
Now we request Dr. Hari sir to present the memento to Dr. Govind sir.